non-invasive ventilation. The learning objectives are: discuss the concept of non-invasive ventilation, list the goals and indications for non-invasive, select patients who should be managed with non-invasive, list the factors that predict success during non-invasive, discuss patient interfaces, types of ventilators, and modes of ventilation used during non-invasive, discuss the initiation and management of non-invasive in the acute care setting, list and discuss complications associated with non-invasive and their possible solutions, discuss the appropriate approach to the initial application of non-invasive. You're going to see the term non-invasive ventilation abbreviated a number of ways, so kind of pay attention and realize what they're trying to tell you. Non-invasive ventilation doesn't require an airway. So the earliest example then is just a resuscitation bag and mask. This encompasses both ventilation and CPAP and is typically provided by a nasal or oral mask. Non-invasive is becoming more and more popular all the time, and that's simply because the equipment and the techniques have improved, especially the interfaces, in other words, especially the masks that we wear. The improved quality of the ventilators, and typically have software available now on your critical care ventilators if you buy that option. And the studies that have showed success, and a lot of times in this chapter, the way they discuss it is like a research project. They'll give you a lot of percentages of success or failure, and depending on what type of patient that is, then they say it's good for this type of patient and not so good for this other type of patient. Types of non-invasive ventilation. A number of types of different ventilators could be classified under non-invasive, and we'll just kind of mention a few of those. The first one is the pneumobelt. This is just a rubber bladder strapped to the abdomen. As the bladder expands, compressing the abdominal contents, pushing the diaphragm, causes exhalation. The bladder deflation then causes the diaphragm to fall and inhalation occurs. Some patients prefer this while in a wheelchair. So there's the picture of a pneumobelt. I can't say I've ever seen one of these. And then there's negative pressure ventilators. Negative pressure around the thorax causes a pressure gradient across the chest wall, and inspiration occurs. The iron lung, which we'll look at in just a second, was used widely in the polio epidemic in the mid-20th century. This thing surrounds the entire body, and the porter lung is a cheaper version and more portable than the original iron lung. The chest cuirass seals around the chest. Looks kind of like a turtle shell and pretty much attached to a vacuum cleaner motor. Negative pressure ventilation fell from use with development of positive pressure ventilation. So here's an example of an iron lung. In the event you ever run across one of these, for me, I have, and it was a surprise. We kind of showed up and there it was. Didn't have any sense of warning at all that it was going to be there. But you can kind of see the patient over here and the viewing panels for looking inside, and then the access panels. Now you can also, depending on how your patient tolerates it, you can actually take the patient out of the iron lung. And so these access panels, if you can't take them out, then you have to use the access panels for patient care, for IV and cleaning them up and whatnot, Foley management. The business end is down here on the other end. And you can kind of make out the rod. This is a leather attachment, if you will, or something similar to that moves back and forth. And it's propelled by this electric motor. So the further this thing moves, the bigger the tidal volume for the patient, the bigger the pressure gradient, resulting in a bigger tidal volume. And then how many trips it makes back and forth determines the respiratory rate. Now, in the event of electrical failure, this thing has a hand rod right here that you can manually move this thing back and forth and at least keep the patient breathing until the power is turned back on. This is a chest cuirass. Kind of looks like a turtle shell. And when this thing is turned on, you notice it doesn't have any straps that go around the back, because when this thing is turned on, it sucks onto the chest and it stays there. And in fact, when it's time for inhalation, you can't talk. It makes you inhale. Now, this shell is rigid, and it has to be rigid so that it doesn't collapse the shell down and it causes the chest to rise. And so you always have to have something rigid there. The same idea, the higher the pressure, the bigger the volume that's delivered. The rate is determined by how many pressure gradients are caused in 1 minute. This is actually a bodysuit, and it's just kind of a different version of that chest cuirass in that this is a suit that you wear. You can kind of see the Velcro straps here at the arm. There's also some on the legs and up around the neck. The neck has to be, tight fitting here. And you notice that it has something similar to the chest cuirass underneath there. Again, you got to have that rigidness so that it doesn't collapse the bodysuit itself, but it causes the chest to rise. And here's a version of the portalung. You can see how it might be a little bit more portable than the original iron lung. So you could actually maybe travel or go places with this. This is box 45-1 on page 1134 of your text. Goals of non-invasive positive pressure ventilation. Maybe the number one goal is to avoid intubation. Improve mortality, decrease the incidence of VAP. Relieve symptoms, enhance gas exchange, improve patient ventilator synchronization, maximize patient comfort, decrease length of ventilation, decrease length of hospitalization. And in the chronic setting, like at home, relieve or improve symptoms, enhance quality of life, avoid hospitalization, increase survival, and improve mobility. The primary indication for non-invasive is hypercapnic respiratory failure due to COPD. And there's strong evidence that it reduces the need for intubation. Also, hospital mortality and length of stay decreases, and complications are reduced. Non-invasive ventilation is the first-line therapy in managing acute exacerbation of COPD. So what does that mean? That means not bronchodilators, not extra oxygen, but BiPAP. For asthma, there's some evidence that non-invasive has good results, where you have an improved PF ratio, PaCO2, and pH. And there may be a reduction in the intubation rates. However, the use still remains controversial. And so what this means is that you'll have asthma patients that benefit from non-invasive, but then you're also going to have some that don't. So you're going to have to pick and choose your patients, or know which ones are likely to benefit from it. Acute cardiogenic pulmonary edema. Numerous studies show the power of the CPAP, and CPAP is the first line of therapy here. Non-invasive ventilation reserved for those with ventilatory failure. Community-acquired pneumonia. NIV is only shown to improve the outcomes in patients with COPD who develop pneumonia. Hypoxemic respiratory failure, or a PF ratio less than 300. This is the first line of therapy for the immunocompromised awaiting transplant and post-lung resection. Non-invasive is very controversial in all other groups. If used, note marked improvement in 1 to 2 hours or accept failure and move on to intubation. There's a 60% mortality rate if intubation is further delayed. Non-invasive ventilation is a good alternative to a patient that has an advance directive that says do not intubate, but only if it makes them more comfortable or to manage a reversible disorder. Postoperative use shows promise. Some evidence shows CPAP post-abdominal surgery improves outcomes. To facilitate weaning in the COPD or CHF patients. For other patients, NIV instead of reintubation worsens outcomes. This may also be helpful in restrictive thoracic diseases. If you have evidence of nocturnal hypoventilation, hypersomnolence, morning headaches, fatigue, dyspnea, cognitive dysfunction. If some of these are present, use the NIV to prevent chronic hypercapnia associated with hypoxemia at night. This helps by resting muscles, lowering the CO2, and improve compliance, FRC, and dead space. For your COPD patients, your use is controversial, but they have come to a consensus and they do recommend non-invasive use for severe COPD with symptoms of nocturnal hypoventilation, and one of the following: the CO2 of 55, the CO2 of 50 to 54 with nocturnal desaturation, or they've had 2 hospital admissions for ventilatory failure. For hypoventilation, associated with a number of diseases including central and obstructive sleep apnea and lung parenchymal diseases. The nasal CPAP is first-line therapy, and NIV is recommended when other first-line therapies fail to alleviate hypoventilation. Patient selection and exclusion and predictors of success for non-invasive. Selection is generally established by signs and symptoms of respiratory distress. This is box 45-3 on page 1140. Non-invasive ventilation selection criteria for patients with acute respiratory failure. 2 or more of the following should be present: use of accessory muscles, paradoxical breathing, respiratory rate greater than or equal to 25 breaths per minute, moderate to severe dyspnea, a CO2 greater than 45 with a pH less than 7.35, and a PF ratio less than 200. Box 45-4, this is the exclusion criteria for non-invasive in patients with acute respiratory failure. So this is the type of patient that would not be considered for non-invasive. Apnea, the inability to protect the airway. In other words, they're a high aspiration risk. Hemodynamic or cardiac instability, lack of patient cooperation, inability to use non-invasive interface because of facial burns, trauma, or abnormal anatomy, and excessive amounts of secretions. Box 45-5, this is predictors of success for non-invasive in the acute setting. If there's a minimal air leak around the mask, low severity of illness, respiratory acidosis with a CO2 between 45 and 92, a pH between 7.22 and 7.35, improvement in gas exchange within 30 minutes to 2 hours of initiation, and improvement in respiratory rate and heart rate.